your iMac.
Perfect. اوكي، اول شيء احب اشكرك دكتور محمد على استضافتك ومبادرتك الجيدة، وان شاء الله احنا نتعلم من خبراتكم في توفير شيء مطابق او مماثل للمتدربين عندنا في التخصصي وفي السعودية كلها.
ده شرف لينا يا دكتور فارس.
Thank you. If I can start a presentation, a topic اللي we sort of agreed on as something new, up and coming, and hopefully will remain or continue to be important in vascular surgery is the topic of image fusion imaging. And just to start with, my hope is that vascular surgery will learn from the mistakes of the cardiac surgery, and it looks like we are. And we should be at the forefront of any new evolution, revolution in our specialty. And if we can improve the care of our patients with our skills, then it should be us, and not saying this is another specialty and we should go to them. But this is a talk about image fusion for vascular surgeons. Okay. So, Anna, what I will cover is a little bit about the history of fusion imaging, what it is, the current software that's available, how we're doing it today compared to before. Also talk a bit about the benefits, what are real benefits, what are not necessarily real benefits, and maybe I'll put a little video and put an illustrated case. So fusion imaging has actually been around for a long time. It's developed by radiologists, definitely, and it was used for different specialities. لكن من ناحية vascular surgery or vascular intervention, it became more interesting or more attractive تقريبا from 2009 onwards. And actually, I had the chance to join one of the premier teams when I was training in France in 2011, and they had just published this article, Zero Contrast Thoracic Endovascular Aortic Repair Using Fusion. So this is a patient with pre-dialysis with a simple thoracic aneurysm that they managed to diagnose on an MRI with no contrast, no gadolinium contrast, and then decided to do the full procedure without the injection of any contrast intraoperatively or actually even post-operatively. So this was published in Circulation 2011, and then I was lucky enough to join this team, and we started doing fusion for probably around 30 or 40% of aortic cases. So we're doing some cases with OR without, and some cases in the endovascular suite, which was not a hybrid OR, but more of a interventional radiology. And we started doing more and more complicated procedures and even of issues using image fusion. So this is one of the cases that for me was extremely interesting. It was a patient very young, or not very young, relatively young, but quite sick and not a candidate for open repair, with essentially a type 2 thoracoabdominal. And the decision was to proceed with a fenestrated and branched device. So actually, once we did all of the measurements, the best fit was for 2 branches to the SMA after completing a T-bar at the top and fenestrations for the renal artery. And at that time, we were doing something slightly different, where we were creating a 5th additional hole in the graft, a branch that would be used so that the patient's aneurysm will continue to be perfused, and that we can slowly condition the spine and only plug that hole under local anesthesia 2 or 3 weeks after the procedure. So we can see if the patient will develop any symptoms of spinal cord ischemia or paraplegia before actually putting the plug. So this was the background of this case. And from the beginning, we proceeded with image fusion and overlay. So the overlay technique back then was a little bit different to how it is now. So the patient would have their CT preoperatively with the DICOM images. And once the patient is intubated, prepared on the table, and we know the patient's not going to move at all, then we proceed with taking images, and it used to take around 2 minutes in different views. Once we had done that, then we look for sort of fingerprint-like identifications in the 2D images that we can overlay to the images on the DICOM. So, for example, we would see a calcification somewhere on the wall of the aorta, and we would also see, for example, a defect in one of the vertebra and an alignment somewhere, or a calcification in one of the visceral organs. And then we would overlay that, line it up, and check. And then once we proceed, then we double check during the procedure by putting catheter, for example, in the renal artery to check, is it really like we thought it was, or has it changed? But, you know, it was not ever utilizable for cases under local anesthesia because the patient...
استفسار صغير يا دكتور فارس.
تفضل.
السلايدز اللي موجودة قدامنا السلايد نمبر 9 من ال 13 سلايد بتاع البرزنتيشن، بس هي ما اتحركتش، فاحتمال الشيرد ويندو اللي حضرتك عاملها مش الاكتف باوربوينت، يعني هي لا تزال من اول ما ابتدينا مكتوب سلايد 9 من 13، فاحتمال شير سكرين المربع. ايوه انا شايف السهم بتاع حضرتك.
اوكي هذا هو هذه البرزنتيشن حقتي.
ايوه
فانتوا
احنا ما شفناش غير السلايد رقم 9، هي ما اتحركتش. انا متهيألي انت بتحرك السلايدز مش كده؟
هي قاعد احركهم، كل هذول ما شفتوهم.
لا ما شفناهم، لا محتاجين. متهيألي الويندو اللي عملت عليها شير ويندو ثابته قدامنا، هتلاقيها باينه عند حضرتك في الفيوينج انها مش الباوربوينت اللي بيتحرك.
اوكي خليني اشوف where it is. هذا اللي انت شايفينها ها؟
ايوه دي اللي احنا شايفينها.
close it. هذيك ما لها دخل. سوري.
That's okay.
Okay, let me try again. أجل. It should be this one. أنا طلعت لي. Okay.
Yes.
الآن do you see image fusion?
Yes. Now I can see the first slide. Yes.
Okay. So let me go to where the parts would be interesting. It was just about the articles. This was a case of a type 2 thoracoabdominal, pre-operative images. And this is the type of imaging that we use when we're designing a graft for a fenestrated or a branched. This case was decided as 2 branches for SMA and celiac, 1 for renal right, 1 for renal left, and 1 extra branch اللي تكلمت عنه for spinal cord.
Excellent.
And this is an image for how we do an overlay. And I think this is essentially where I got. But this is the initial post-operative CT and how it looked like when the procedure was just completed. And then the patient was actually not someone who was following up, and he came with abdominal pain and with this beautiful looking image here. So you can see a dislocation of a superior mesenteric artery branch with a very large endoleak and a growing sac. And we tried to enter from above, from below, and as you can see, a wire just keeps on coiling, and it's impossible to get enough force to put this correctly in line. So what we proceeded to do is we said the only way to really approach it is from the SMA, and we utilized image fusion, and this is the old style of how it looked like, not very clear, and I'll show you some other images.
Yes.
Where we can identify the orifices of every artery, every branch vessel, and we were able to identify exactly where the SMA is lying, and we were ready to do a direct puncture through an abdominal wall. Then we were concerned actually about the closure device not functioning. So we did a small incision directly on the SMA, about 3 centimeters, and we directly punctured the SMA. Once we were there with the ability to improve the forces there, and then able to also snare it from above, we were able to put back the artery in line and then place a bridging stent and correct that. Now, this is really the old style of doing things. And most of the new systems have excellent software that comes with it that solves a lot of the problems that we had in terms of the time it takes to line it up, the need to be really very specialist in the procedure or in the use of fusion to be able to get a good alignment. Also, it was very cumbersome. If the patient moved on the table due to they were under GA, but you need to reposition, then you would have to do it all again. So almost every big company has created now their own software. So GE, for example, on the new Discovery that they have, the 730, provide these 3 softwares to try and make it very easy to do. So if someone's doing an EVAR, TVAR, you're able to take the CT scan from the beginning, and it will show you the full planning of the procedure. It will show you where the target vessels are. You can check it and readjust it. It will even give you, if you're using a certain device, which device you should use and what sizes. So it's almost, I wouldn't say automated, but semi-automated software that takes you from pre-procedure, peri-procedure, and then even provides you imaging at the end of procedure to help you be convinced whether your treatment is sufficient or you can do something on the table. And it comes with different software. So Vessel Assist is highly utilized by interventional radiologists, and I'll go into that. There's also, because it's very expensive, products used by, for example, interventional cardiologists for TAVI or for PCI, and more liver are using it for intraoperative chemoembolization or embolization in general. So really it's growing. And this is not just true of GE. Philips Azurion has a very comparable product. The only difference is, one of the main differences is it's hanging from the roof. But as you can see from the bottom part here, you're really taking everything from the beginning. So you're taking the images to decide what you will be doing, whether it's IVIS or the X-ray images or the CT you had before. You guide your imagery knowing exactly where you want your wires to go, and combining the preoperative CT with the post-operative. So it draws you a similar picture to what you would have on the GE. And then at the end of procedure, you're able to confirm whether your intervention was corrective, not just by normal fluoroscopy 2D imaging, but IVUS built-in and 2D perfusion. And I believe that's unique to the Azuri and the 2D perfusion. Siemens have something similar and actually have a robotic arm. So this is the most expensive device out of the others. So you have no issues about the amount of rotation or the angles that you want to get on the device, because it's highly functional due to the robotic arm. But in my opinion, the software is a little bit more complicated to use, at least for me. So really, should we be using fusion? What's the proof for that? The most obvious proof is the amount of dose of X-rays that we're getting. And I have become personally very paranoid about the amount of X-rays that I'm getting. And I think more and more people are feeling that. And, it's really a high risk. And when you look at some of the very, very high-end centers, for example, Lille, which was the center of Stefan Holon until 2 years ago, they're able to reduce the amount of X-ray by 34 times for a standard EVAR. So really, when you have that kind of volume, and you're reducing your dose that much, there is no situation where for your own safety you should stop or take a break and not get more exposure. And this is really a huge benefit. Another very impressive benefit is the time for the procedure. And I'm not just talking about the intraoperative time. The intraoperative time is extremely important because you know with the imaging, and I'll go into that later, what working angles you need, where you are, if you're in the right position to see which vessel. So yes, that's extremely useful, but it's even reducing the preoperative time in terms of preparation. So instead of taking the CT, taking it to someone else's laptop, like one of the companies, getting them to read it, meeting with them to discuss it, ordering the device, you can actually put it into the device from the beginning, so it's uploaded, plan your procedure, including which devices you're going to use, and proceed to the actual intervention itself. The post-operative, now a lot of these devices also essentially are a CT machine. So you're able to do an on-table CT scan, and that can help you to, for example, reduce your kind of follow-up from number of CT scans to, for example, just ultrasound, because you're already confident about what went on in the procedure. The other, probably most important part is the contrast. And the contrast used is at least half of the amount, and this is for a standard EVAR. If you look at the contrast used for complex, fenestrated, branched, very often it's 200 ml or more, and you can reduce that by 3 to 4 times just because you're using this guidance. So the EVAR assist software that comes with GE essentially is the same as what you would have with what we discussed earlier, the Philips Azurian. So you load it up preoperatively, it automatically puts most of the imaging. You just have to double check, realign it, and then it will load it up onto your operative console for utilization during the procedure. And then you can complete it with a completion cone beam CT with or without contrast. So this is an example of what it looks like on the GE, because this is the device that I have access to and I'm more familiar with. once you put in your CT scan to essentially come up with all of these lines that we have shown. So you indicate to it what procedure you want to do. So EVAR assist. It would show you this image on the top left here. And you would have to obviously double check, really, is this line going to the left renal or not? Are these zones the zones that you are thinking of as your seal zones for your EVAR device? Are you planning to insert it from the right? Because this looks like what the plan is here as the automatic. And once you've done that, it will give you all of the dimensions of these important areas. It'll show you the levels of the target vessels that you're interested in. So if you're planning to deploy below the renals, then you know exactly where it is, and it will move with the table as you are doing the procedure. And sometimes you may need to slightly realign it. The wires, for example, if they're stiff in the iliacs, external iliac in particular, it will not be like it is on the CT, obviously, but the aorta itself, the common iliac, does not move. The target vessels like the renals, the ostium does not move. So if you're only interested in the position of where the origin of the artery is, which is almost always the case, then it really doesn't make a difference. The fact that you're using a previous CT as opposed to a live image. It's much more important if obviously you're going for stenting a distal part in one of those target vessels. This is an example of a fenestrated case. So you can see the device inside the normal 2D, and you can see the outline from the preoperative CT scan showing the target vessel. So celiac trunk, SMA, right renal, left renal. So if you're planning to deploy based on the position of the renal, for example, then you know just by looking at this image that you're not in the perfect position, because it would have to be a straight line for you to be sure that this is a fully aligned perpendicular image. And you can do that just by looking at this image instead of taking 2, 3, 4, 5 injections to see if this is correct. And actually, you almost never know because you're basing your opinion based on a 2D. So if you look on this image, for example, this is the part of the procedure where you're cannulating the SMA. And you can see here, it's the perfect position for cannulation. It's almost a straight line. You can see exactly where the markers are. And instead of, am I still there?
Yes, you are there, and we can see your slides very well.
So I cannot see my slides anymore. Somehow it, let me check again.
Okay.
Which, okay, yeah, I'm back. And once the procedure is completed, you most probably don't want to give more contrast on the table because you probably have given enough than what you would need, but you're actually able to see better images with a non-contrast cone beam CT that can show you things such as, is the stent fractured? Does it have too much compression? Is it too much in the aorta or too little? Is the flaring that was done enough or not enough?
We have a question. We have a question from one of the NTD, Dr. Muhammad Salah Qabis. Do you like to have his question and then we'll continue after that?
Sure.
I will unmute Muhammad. Okay. You can ask your question, Dr. Muhammad. Your voice is on, Dr. Muhammad Salah Qabis. He did write the question in the chat room. can CT fusion used in leaking aortic aneurysm as patient in this setting with leaking is under local anesthesia and not under general anesthesia. هو بيقول السي تي فيوجن تكنولوجي ممكن نستعملها في leaking abdominal aneurysm.
Okay, so two big advantages of using it in a leaking aneurysm. Number one is there are some centers who receive a lot of ruptured AAAs. They go by clinical suspicion. For example, hypotensive patients with a history of AAA, they would not actually take him to the CT scan. They take him to the hybrid OR or the cath lab, and they will do the CT, the diagnostic CT there. So you don't have all of the transfer time issues of going from one place to another. And you actually get the CT in the place where the patient will be more stable. So if you find that it's not a AAA, then you have the diagnosis from the CT. For example, it's an abdominal surgical issue that needs to be dealt with, then the patient's already in the OR. Or if it's an aneurysm, then the patient's at least in the best place for him. So the diagnostic part is a big advantage. Can you do it in general under local anesthetic? I think with the new software, because it is so easy to adjust, so the lines that I showed you in this image, within 2 seconds, if the patient moved left or right, you can readjust it. Obviously, if you were in this situation and you had a catheter, you know the SMA is here, then you can, and actually the patient moved, so you see the drawing that the SMA is here, you can easily realign it. So the answer is yes, you can use it under local anesthesia. And I'm not going to get into the fact that I don't like doing ruptures under local anesthesia, but the answer is yes.
Okay.
I hope that's an answer.
That's great. Yeah, we can continue. Yes.
Okay. So actually, I have a video of it playing, but I have to go to another screen. So I think I'll have to switch the screen view. So just give me a second.
Okay, no problem. If anyone of the 30 candidates we have a question, he can press on the bottom, raise his hand, and then I can allow him to speak. And if this meeting, the 45 minutes has ended, I will start the same meeting again with the same ID, so you can join in without any problem.
Can you see this?
Yes,
can you see my mouse moving?
Yes, I can see another screen.
Okay.
And now I can see the video. Yes.
Okay, let's just make sure it's
opening the door.
Maybe it's not playing. Let's
I will present you a case of a 67-year-old male patient.
Excellent.
We're going to use this of CT angiography to prepare the imaging to use during the operation with fusion. You see how intuitive it is on the vessel assist workstation. We just use one click on the mouse and the automatic bone removal is already done. I want to select the right extremity. So we start at the aorta point and then we select the right leg. The center line tracking is running automatically up to the occlusion. At the occlusion, we need to start our bridging tool from the beginning of the occlusion up to the end of the occlusion. And from this point on, we can continue our automatical vessel line tracking up to the ankle. After the automatical center line creation, of course, we need to edit our trace. So with the edit tracing tool, we can really adapt to the local anatomy in a manual way. And so following the lesion from the distal to the proximal part or vice versa. So in this way, it's perfectly adapted at the level of the lesion. We know out of the aortic field how interesting it is to have stretched views in order to prepare your procedure and to measure the devices. Well, we can use the same here with our vessel assist in the peripheral area. You see how interesting it is to have the stretch view through the occlusion. With the ruler, we can easily measure the length of the lesion from healthy vessel proximally up to the healthy vessel distally. I measure almost 12 centimeters, what is very worthwhile information to have during the procedure. I can order the correct tools, the correct devices in advance to treat the lesion. Another interesting tool on our vessel assist is the planning line. It's always interesting during your operation to have landmarks where the occlusion starts, but more important, a landmark where the re-entry site is. So here we run through the axial slices and you can see the SFA, calcium in the mid portion, and at one level here starts the occlusion. You see a bunch of collaterals. I create an orange circle at the beginning point of our occlusion. I'm creating a second planning line, green circle, so this will definitely indicate the zone of re-entry at the P1 segment. Now we can create the subvolumes. This is the bone subvolume. Here we have the vessel plus calcium, and you can also create a subvolume with calcifications only that you can easily use during the D-view registration intraoperatively. So at the end of our preparing work, we can just save all the information we have. You can do this like 1 week in advance, and you can use it the day of the operation. So now we're going to start our B-view registration from table side. We're going to use our preoperative work here live in the operation. Here I have the selection of these subvolumes, or bone, or the vessel, or the calcification. Because I see on fluoroscopy some of the calcifications, I'm going to select the subvolume calcification in order to use it during the surgery. And here you can see that we have this accuracy score. So at this moment it's 0%. If we are selecting another angulation, you see it's arriving in the yellow and finally in the green area. So it means that these two angulations are perfect to create our registration. We can start our adaptation to the live images. As you can see, I select the translate rotate function. We adapt in a quite easy way the position of the calcium. There you see, I think this is already a quite accurate fusion. So from this moment on, we can use the live images and to be guided by the landmarks and the center line that is created pre-operatively. Here you can see this very clear how accurate our fusion is. So we start the recanalization. I'm already there at the beginning of the occlusion with a 018 wire supported by a catheter. And so here you see how nicely I'm guided by the green center line and the green circle, the beginning of the occlusion. And you see here that I'm really losing the path of the center line. So what is for me a clear indication that I'm entering a collateral and that there is the risk of creating a perforation. So this is the high value of having this fusion during my recanalization. So I'm pulling back and I try to select another track. So we have to go back to our green line and try to follow the center line tracking. So now I found another track, as you can see, and so we are following now quite close the center line. So unfortunately here in this case it is impossible to recanalize from the anterograde approach. So then we switch to the retrograde approach. And the nice thing is that we have this preoperative center line. We did it right up to the tibial vessels. So we have the central line now again fused in our live images. We can use it really to puncture the proximal anterior tibial vessel. You see during the advancement of an 018 wire how precise the fusion of the central line in our live intraoperative image is done and is following the pathway of our wire. Originally, the orange marker was planned as a re-entry marker. Because we switched our access to the retrograde way, you see that we can use it as an entering marker. And so at this point, the occlusion starts, and you see how accurate, how precise our 018 wire is now following the center line intraluminally through the occlusion, and the green marker now is the clear re-entry site of our SMA. After passing the lesion, you can notice interesting it is to have these markers in the screen with the fusion. So I don't need to make additional angiographies to be sure of the precise balloon placement. So based on the green and orange circle, I have a perfect idea where the lesion is and where I need to start my pre-dilatation. As a summary, I can say that every time I'm using this fusion, I'm impressed first of all of the easiness and the intuitive character of these preoperative planning, and I can notice that we are able to reduce in an important way the amount of contrast, the amount of radiation, and also important is an increase of our technical success rate.
Okay, I'll just go back to the PowerPoint slide.
That was an excellent video, Professor Faris. That was very great video.
Great. So if there are no questions, I'll continue with a case that I did. So this is a peripheral case. Oh, it's not playing. Okay, so this image is not playing, but it's a peripheral case of a patient who had, who was relatively young and was referred to me by an interventional radiologist with query vasculitis. So he has a very small aortic diameter infrarenally and both iliacs. And I did for him an MRI and a vasculitis screen, which was all negative. And his problem was claudication and impotence.
Do you prefer MRI over CT angiogram, or what do you think is the optimal?
For me, I feel CT angio is the best for planning and general diagnosis. But when it comes to vasculitis, I feel that MRI has a better specificity for specifically vasculitis. So it's very rare that I would do an MRI, but if there is a question mark like this patient, then I just decided to do an MRI. But the fusion that is being used here is based on his CT actually. So you can see on the CT scan the very tight aorta. It was measuring around 3 millimeters, 4 millimeters in diameter, and the iliacs were around 2 millimeters. So this is what it looks like on the console once the DICOM images are uploaded to, this is the GE system.
Good.
And you can see here, this is the normal bone overlay intraoperatively that you would have. And you can actually use it to show you the bone markings from the CT scan, but without showing any of the arteries. So this can be useful in some situations. You can use purely the arterial images from the CT scan overlaid onto the fluoroscopy image. Or you could use the normal DSA, and you can see just the amount of information that you get from the normal CT here compared to the fluoroscopy. So in this situation, you don't clearly see where the renals are. Due to the occlusive nature of the sheath, you don't really see what's going on in the right common iliac. You cannot see the internal iliac. So there's a lot of information that you can get without using any contrast, that actually in some situations is more than if you use contrast. This is, I'm trying to remember what image this was. Oh, it seems like for some reason unfortunately the images are not playing from the videos.
Okay, that's no problem.
But what we have here, for example, is there was a situation where the overlay was showing the wire going into a plane that was not the iliac vessel. And it was actually going very smoothly by hand. I would have absolutely no questions that I was in the true lumen. But on the CT scan, I could see immediately that I was a few millimeters away from where the actual lumen was. And so I decided to proceed with the left side first. And the left side showed the verification that the alignment of the CT was correct. So actually really what I was seeing, that was my wire was going into a dissection plane in this very soft iliac vessel that I would have had no clue just by feeling that what it was happening.
Okay.
And the end was able to complete a standard CRAB or Eiffel Tower technique. So this was a V12 10 by 38, I think, in the aorta, followed by recanalization of this very small, or probably occlusion by the time that the procedure was done. And the second aortic stent was inserted. And you can see here what I was saying about the iliacs, that once you put, for example, a stiff wire or a long sheath, which is what I'm using here, the alignment of the iliac changes compared to the preoperative CT. But if you have a catheter only, so something soft, the alignment looks perfect compared to the preoperative CT. Okay. So you can see here the insertion of two sheaths, and unfortunately none of these videos are playing. I don't know why that's happened. With the completion angiogram and the verification here that in fact the wire was in a dissection, which was absolutely not felt by me by hand. So that was a good indication for me, that I may not have realized at the time, that indeed this is for sure a dissection, and I was aware of it from the beginning. So the choice to put an extension stent was an easy one to make in this situation. And this should have showed, I think, the final angio. So as we saw a little bit earlier, this is the kind of information and the kind of cases that would benefit from the vessel assist, by essentially really planning your procedure before you even have the patient in the room, what stents you're going to be using, what wires, how long they're going to be, entry-exit sites, and awareness of any errors related to going into dissection when you don't want to, or being aware that you're in the subintimal space. At least if it was intentional, you know that. If it was unintentional, you can come back. So really, in summary, I think if you have the money to access fusion imaging, then it's really something that can make your procedure much more enjoyable, shorter, less radiation, and actually effectively less time. I would say that for complicated aortic procedures, fenestrated, branched, in my opinion, it's pretty much becoming a prerequisite because the outcomes, especially in terms of renal failure, are already very risky in this kind of procedure. So not utilizing the added benefit of fusion imaging makes the outcomes really borderline compared to what they could be. So this is a rerun of some of the images we saw earlier in how the vessel assist can really give you a perfect navigation of the position of the artery, and the fact that it doesn't really move if you're not using either very stiff, ultra stiff wires like Lunderquist's or Amplats or long sheets. So it's very dependable to use. And that's it. I hope it's
excellent. That's an excellent presentation and excellent information about image fusion, which is a topic extremely important to vascular surgeons. So I will open the floor for discussion, and we have the opportunity of Professor Faris Omran with us. So if you have a question, please raise your hand, and I will start by the first question. If you have a tortuous aorta and you done your fusion imaging with a dicom loop before you start and you put it into the system, the Lunderquist wire, the anatomy, it changes. Do you change the fusion imaging while you work? You mentioned in your case when you get a tortuous iliac artery and you put a stiff wire, the anatomy doesn't change. Do we have a software that can adapt with such tools, or we don't have?
That's a very good question. So do we have a software? To my knowledge, no. I'm not aware of any software at the moment that can adapt to that. And I think it's probably going to be a very far way away in terms of technology, because in my opinion, for you to be able to do that, you will need some kind of feedback from the wires or the devices that you're putting in to somehow coordinate. So I know that there was, this is a big issue, for example, with the Magellan robotic device that was something that looked very exciting 5-6 years ago. And the idea was that you would be able to essentially put like a GPS coordinate. Please go to renal artery 2 centimeters after the ostium and navigate there and maybe put a stent there. But we know it hasn't reached that level of technology because you cannot get feedback from every part of the system, including the materials you're using. Will it happen? I don't know, but I think it's still a far way away. But what I would say is, for the iliacs, absolutely true. The wires and sheets are a big issue. It does cause a lot of movement, and we need to be aware of that. But in fact, for the aorta, not really. The aorta moves very, very little. It's quite tethered, and the problem is where does the device lie within the aorta? So is it on the left lateral? Is it anterior, posterior? So that's where the problem happens. You will still see